네, 발표 부탁드립니다.
Hello everyone, I'm Kil Sung-moon, Clinical Fellow at the Thyroid and Endocrine Surgery Division. The topic I will present is a report on our 20-year adrenocortical carcinoma experience, which is an ongoing study. Adrenocortical carcinoma, ACC, is an extremely rare cancer with a prevalence reported in various literatures ranging from 0.5 to 2 per 1 million people. The purpose of this study is to confirm and report the treatment and results of ACC patients diagnosed at our institution. From January 16, 2022 to November 2, 2022, we reviewed 1,281 patients who underwent adrenalectomy at the endocrine surgery department of our hospital, and as a result, 12 patients who were pathologically diagnosed with ACC are identified. Age at the time of diagnosis, sex, tumor size, tumor direction, clinical symptoms at the time of visit, stage, hormone secretion, and details of treatment were checked. All patients underwent an overnight 1 mg dexamethasone test to detect Cushing's disease and a 24-hour urine metanephrine and catecholamine concentration test to detect pheochromocytoma. Computed tomography was performed as an imaging test for all patients, and MRI and PET scans were additionally performed as needed. For the stage, the staging systems of European Network for the Study of Adrenal Tumors was followed. For pathological diagnosis, the BICE criteria, which is most commonly used worldwide, was followed. It is a system in which 9 parameters each have 1 point, and if 3 or more items are applicable, ACC is diagnosed. Result. Of the 12 patients, 3 were male and 9 were female. The mean age at diagnosis was 49 years old. The direction of the lesion was left in 7 patients and right in 5 patients, and there were no patients with bilateral lesions. At the time of diagnosis, 6 cases were diagnosed incidentally, and other main symptoms were general edema in 1 case, general weakness in 3 cases, and gastrointestinal symptoms including abdominal discomfort or pain in 2 cases. The average tumor size was 8.82 centimeters. The minimum size was 2.3 centimeters and the maximum was 19 centimeters. There were 7 functioning tumors and 9 non-functioning tumors. Functioning tumors were all cortisol-secreting tumors. This is consistent with what is known in the existing literature that the most common type of functioning ACC is a cortisol-secreting tumor. The stage had 3 stage 1, 6 stage 2, 2 stage 3, 2 stage 4. 2 stage 4 patients had lung metastasis and liver metastasis respectively at the time of diagnosis. For postoperative treatment, 5 patients received single chemotherapy and all were treated with Myrtane. In one case, at the time of surgery, the abutment of kidney and adrenal tumor was confirmed and postoperative radiation therapy was performed on the resection margin. The patient was recommended to receive chemotherapy at the same time, but this was not possible due to the patient's anxiety about chemotherapy. One patient underwent both chemotherapy and radiotherapy after liver metastasis occurred. The average follow-up period was 591.8 days. The median for disease-free survival was 212 days, and the median for overall survival was 277 days. This was a rather small value compared to previous studies, which is thought to be due to the fact that the follow-up period was rather short, as 50% of the patients in this study group were diagnosed within 3 years. 10 of 12 survived, and 3 experienced recurrence. The information on the treatment and survival of the patients was summarized in the table as follows. One patient developed metastasis to the OP bed and lung, but refused any additional treatment and no further treatment was performed. One patient received palliative chemotherapy, including Myrtane, for lung metastasis and liver metastasis. The other patient had liver metastasis and the aforementioned chemoradiation therapy was performed. One of the two deceased patients was a 72-year-old male patient who was recommended chemotherapy after diagnosis but refused and died about a year after surgery. The other is a 40-year-old woman who was previously classified as a recurrence case. Liver and lung metastases were diagnosed 1 year and 3 months after surgery, and palliative chemotherapy was performed, and the patient died 4 months after recurrence. These are the pictures of the Kaplan-Meier survivor curve based on disease first survivor and overall survivor, divided into stages 1 to 3 and stage 4. There was no statistically significant difference between the two groups, but it seemed difficult to have statistical significance because the number of patients in each stage was not sufficient. For discussion, complete all-zero resection is the only curatively effective treatment and has been mentioned as a valid prognostic factor in a number of existing papers. However, as many adrenal tumors are already rare and adjacent to the surrounding organs at the time of discovery, careful surgery by an experienced surgeon is required. In this study, R0 resection was performed for all patients who were enrolled, but there are conflicting opinions about what to do if the tumor cannot be completely removed. Although it is a somewhat past study, there were results in the previous study not be completely removed. Doing the debulking operation as much as possible helps to increase the survival rate. However, other studies have suggested that this strategy has no benefit in increasing survival. The current ENSAT guidelines recommend selectively performing debulking operation for unresectable ACC only in special circumstances such as severe hormone secretion. In conclusion, it can be seen that establishing an individualized strategy is an important part. Routine lymph node dissection has also been controversial in several studies. A German study published in 2012 reported that performing lymph node dissection in all ACC patients, regardless of stage, contributed to an increase in survival rate. However, an American study published in 2018 presented conflicting results that lymph node dissection did not help improve outcomes in stage 1, 2, and 3 patients. In the 2018 ENSAT guidelines, it is recommended to routinely perform a local regional lymph node dissection for diagnosed ACC, regardless of stage. In a meta-analysis paper published in January of this year, it was concluded that there is an oncologic benefit in performing local regional lymph node dissection even in stage 1, 2, and 3 patients, and announced results supporting the recommendation. However, in the guideline, even if ACC is later reported in a complete adrenalectomy patients who did not perform lymph node dissection in anticipation of disease other than ACC, including benign disease, reoperation for lymph node dissection is not recommended considering the risk-benefit. Post-operative chemotherapy using mitotaine has also been controversial. If stage is higher than stage 3 or R1 resection has been performed or Ki67 level is higher than 10%, the risk of recurrence is high and chemotherapy is recommended, which is acceptable worldwide. However, on the contrary, it was a controversial part as to whether chemotherapy was required after surgery in low to moderate risk patients who were diagnosed as on stage 1 or 2 and underwent R0 resection and whose Ki67 level was less than 10%. This is also a part of the 2018 ENSAT guidelines that did not clearly support or oppose it. This is said to be largely due to the lack of evidence that there has been no randomized control trial conducted on this part so far. The result of the first randomized control trial on this were published early last year. The result of this study showed that in the stage 1 to 3 patients with a Ki67 level less than 10% who underwent R0 resection, the use of osmanthus mitotaine had no oncological benefit and routine chemotherapy was not recommended for this patient group. There is also no clear consensus on when a radiation therapy should be performed after surgery. Currently, the treatment is being considered for the R1 resection patient group. In a meta-analysis of postoperative radiotherapy on the ACC published in 2019, the patient whose resection margin was positive and tumor size was larger than 10 centimeters and stage was 2 or 3 showed that postoperative radiotherapy lowered risk of local recurrence. This is retrospective study, and as it is an extremely rare disease, the limitation is that a small number of patients was enrolled even after a long-term patient group investigation. This made it difficult to compare treatment method and prognosis according to stage. To overcome this, a collaboration with our institution's data center to check for missing data and collect them is in progress. In addition, during the same period, among patients who did not undergo surgery in the Department of Endocrine Surgery, 3 patients diagnosed with ACC were identified in the Department of Pediatric Surgery, 4 cases in the Department of Hepatobiliary Surgery, and 3 cases in the Department of Urology. I think that increasing the volume of research even a little through collaboration with the other department can also be the one way. In conclusion, it is clear that ACC is still a challenging disease with poor prognosis. However, on the premise of the complete resection, establishing a strategy that appropriately applies various treatment methods seems to help overcome this disease. Thank you for your attention.
네, 문길 선생님 발표 감사합니다. 그 발표 내용에 대해서 참석하신 선생님들께서 질문과 토의 사항 있으면 부탁드리겠습니다. 문길 선생님, 제가 한 번 여쭤보면 아까 다른 분과에서 시행한 수술은 제외했다고 하셨던 건가요?
네, 맞습니다.
굳이 케이스가 모으기 어려운 환자인데 제외하신 이유가 있으시죠? 왜냐하면 치료 가이드라인은 시행한 분과가 수술 시행한 분과에 따라 다를지 몰라도 결국은 헤모 레디에이션은 프로토콜대로 진행됐을 것 같은데요. 성인이나 소아나 뭐 유럴로지에서 수술했던 건 혹시 제외한 이유를 좀 말씀해 주시면 좋겠고, 아까 림프노드 디섹션에 대해서 이게 필요하냐 아니냐 말씀을 주셨는데 이제 우리 여기 발표하신 12명 환자에 대해서는 그 노달 이시전 스테이터스에 대한 얘기를 안 해주셨는데요. 혹시 그거에 대해서 언급을 좀 해주셨으면 좋겠습니다.
네, 교수님 질문 감사드립니다. 먼저 어떤 특정한 연구에 지정이 되는 사유가 있어서 탁과의 수술을 배제한 것은 아니고 현재 연구가 진행 중인 연구인 관계로 일단 본 분과의 데이터부터 정리를 한 상황이고 가능하다면 각 다른 과의 데이터를 추합해서 추가적인 데이터를 포함해서 연구를 진행할 계획 중에 있습니다. 또한 두 번째로 질문해 주신 림프노드 디섹션에 관한 사항은 아무래도 본 연구가 후향적인 연구이다 보니 과거의 수술 기록을 통해서만 림프노드 디섹션 여부를 확인을 할 수가 있었는데, 물론 이제 자세히 기술이 된 경우도 있었으나 림프노드 디섹션 시행 여부에 대해서 과거의 기록 중에는 명확하지 않은 경우가 많이 있어서 해당 부분에 대해서는 일단 본 연구에서는 명확하지 않아서 조사를 포함시키지는 않은 사유가 있었습니다.
네, 감사합니다. 또 다른 질문 있으신가요? 혹시 그 교신 저자이신 강상욱 교수님 들어와 계신가요? 안 계신 것 같은데.
네, 이쪽입니다. 강상욱 교수님이 지금 잠시 해외 출타 중이셔서
네.
대신 말씀을 드리는데, 저희가 지금 갑상선 내분비 외과만의 케이스로 하자니까 좀 케이스가 적고, 아까 임경 선생님 말씀하신 대로 탁과의 데이터와 또 지금 롱텀 팔로업 데이터가 아닌 환자들도 좀 이제 섞여 있어서 저희가 조금 더 그러니까 레어한 케이스고 조금 더 좋은 연구 성과를 보이기 위해서는 아까 문김성 선생님도 얘기했고 임경 선생님 지적하신 대로 우리 병원 안에 데이터 캔서 아드레날 코르티코 칼시노마 환자들을 조금 더 모아서 좀 더 롱텀하게 또 림프노드 다이섹션 같은 경우도 말씀을 드렸지만 저희가 수술 기록지로만 확인을 해야 되는 한계점이 이 스터디의 명확한 한계점이라고는 할 수는 있겠는데요. 조금 더 풍성한 데이터와 좀 더 롱텀 팔로우업을 가지고 세브란스 결과를 저희가 다시 좀 손봐서 나중에 퍼블리시 할 수 있도록 그렇게 계획을 세우도록 하겠습니다. 감사합니다.
감사합니다. 질문도 있으시면 부탁드릴게요. 네, 질문도 없으신 것 같고요. 이제 이것으로 그 두 분 발표에 대한 그 리서치 세미나는 마감하도록 하고 그 전체 채팅창에 올려놓은 그 평가표 작성 부탁드리겠습니다. 예, 감사합니다.